Hello, my name is Carl. I am a paediatric emergency medicine doctor. Today, we're going to continue talking about acute behavioural disturbance in kids and focus on learning from 3 case examples. We then talk about how you can learn in your department from debrief. Firstly, case 1. We have a 5-year-old girl, Becky, who presents with agitation and behavioural dysregulation. She has difficulty with emotional regulation. She is not on any medications and is on a waiting list for further evaluation. Tonight, she has been particularly violent towards her mum after she was not allowed to have her candy before dinner and had begun biting and kicking. Mother and child arrive in A&E. Mum is tearful. Becky is agitated and screaming as she does not want to be there. You enter with a calm tone, a low voice, and introduce yourself to Mum. Whilst you keep some distance from Becky at first and ask the mother what Becky enjoys at home, Becky then hears you and says she likes to draw. You ask her directly, "Would you like some crayons?" She initially refuses talking, but then says yes. You bring some drawing materials and crayons, and as they draw together, you comment on how much you like Becky's drawings. You're then able to start to take a history, do an examination of Becky, and make an assessment. The key points here are the use of a calm, low voice, maintaining a safe distance at first, keeping at eye level, utilising the family on tips for how to best to relate to the child, and the use of distraction techniques. Always address the agitation first. The rest can and then should follow after. So, low sensory approach, use of play and distraction, and ask caregivers for tips. Case 2. You begin your next morning shift. A 14-year-old with a diagnosis of bipolar disorder has been boarding in A&E for the past 2 days, awaiting placement following agitation, self-harm, and suicidal ideation. Her name is Beth. Beth has been cutting herself and has several scars on her arms from when she has got upset at home. At initial assessment, the team had spoken to her about how best to redirect her when she becomes agitated. Beth likes music, and the family note she was previously taught breathing exercises. At the beginning of the shift, her modified overt aggression score is 1. She refuses to talk to the team. You offer her some music and breathing exercises, which she refuses. An hour later, her score is 2. She's on aripiprazole and is due for this medication in an hour. You discuss if she'd like to take her medication early, and she agrees. You continue to offer her music and ask if anything else would help her feel better. She states that she is tired of staying in A&E and is bored. She didn't sleep well and has nothing to do. The A&E team offer her an activity kit that they keep for boarding patients. After Beth receives her medication and the kit, a score is repeated and is now 0. The team note that it might have been helpful to offer her an activity at the beginning of each shift. Key points here. Assess for specific de-escalation techniques at the admission of a young person. Develop a personalised plan. Monitor using some sort of scoring system. Track progress and keep a list of techniques that have worked and also have not worked. Perform structured handovers and update care plans so that this information is understood and communicated to those responsible for care. So start out knowing what has helped before. Personalise plans and keep them updated. Monitor using an agitation scoring system. And ensure structured handovers across shifts. Our last case, a 12-year-old male patient with autism who is non-verbal, who has been boarding for 3 days in the A&E department, awaiting social care placement. Bruno initially presented due to self-harm behaviours at home, consisting of head banging, as well as violent behaviours towards parents, including biting and hitting. A thorough physical examination and evaluation has ruled out any obvious medical cause of his agitation. Bruno is on risperidone in the morning and clonidine at night. At noon, it is noted he becomes more agitated with an increasing modified aggression score. But he has not responded to his typical de-escalation techniques. His family is not available. He attempts to leave despite multiple attempts to verbally redirect him, and he refuses any oral medication offered. He has previously been a danger to himself, running into moving traffic. It was noted oral olanzapine had been used in the past without adverse side effects. There is a discussion among the team about using planned physical restraint for as short a time as possible to administer intramuscular olanzapine safely. With security and senior supervision, staff apply a 4-point restraint and the nurse gives him intramuscular olanzapine. Verbal de-escalation, talking to him, continues throughout, and after 15 minutes he starts to calm down. Staff slowly remove restraint from one extremity at a time. The patient is drowsy but not completely sedated an hour later. Monitoring is applied. During a team debrief, it is discovered he was not given his risperidone that morning. A discussion is had as to how to ensure Bruno receives his daily medications on time, and the checklist, including such things as meals and other comfort measures, is made for when the family is not available. Key points here. Medication on admission is imperative. Besides regular medication, ask about what else has helped in the past. Develop an agitation plan whilst the family are present at the start of care. Physical restraint is a high-risk event, and time doing so should be minimized, with the goal of restraint being in place for as short a time as possible. Whilst restrained, monitor for medical adverse events and continue efforts at verbal de-escalation. Debriefing should occur after any physical restraint. This is to ascertain cause or any triggers, to determine what de-escalation techniques were successful or not helpful, and then to modify existing care plans and lessons learnt. Consider tools for ensuring routine of activities, including checklists. So, develop a plan in advance, medication history, use checklists to support care, document, and debrief. A short word about racial discrimination and Afro-Caribbean race. This group in the United States have historically been disproportionately subjected to the use of Section 136. They have had longer average lengths of stay in hospital and are less likely to be offered psychological therapies compared to other children. Don't be part of the problem. Acknowledge any racial biases you or others may have, and be thoughtful in addressing such issues in your teams. Thank you for listening to this series of cases. I hope it encourages you to utilize every opportunity in the care of an agitated young person as an opportunity for learning and emotional growth, both for yourself and your patients. Next time, we're going to delve deeper into how you can learn from debrief.